Hello, and welcome to part 2 of our recorded webinar series, Lessons from Complaints, a series on injection-related best practices. My name is Brent Booker, and I'm the Assistant Registrar for Review and Resolution at the College of Pharmacists of Manitoba. If you haven't had a chance yet, we strongly encourage you to view Part 1, Best Practices Review for Pharmacists, as it serves as a comprehensive refresher on best practices for injection-certified pharmacists. If you have finished viewing Part 1, please ensure you complete the Learning Activity Education form to receive your statement of participation and claim your continuing education units. You can easily access it by scanning the QR code on your screen or by visiting the CPHM website's accredited Learning Activities page under the Recorded PD Events section. This learning activity is accredited for 0.75 CEU. Before we start the formal presentation, I would like to begin by acknowledging that we recorded these learning activities from the CPHM office, which is situated on Treaty 1 territory, and that the land on which we gather is the traditional territory of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the traditional homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to moving forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. Our speaker for Part 2 is Ms. Shannon Trapp. Shannon is a dedicated pharmacy manager and the chair of the Complaints Committee, holding a bachelor degree in science, a bachelor degree in arts, and a bachelor degree in science of pharmacy. When not in the pharmacy, she's an amateur triathlete and a women's league soccer player. Shannon also indulges her interests in rock and mineral collecting, enjoys painting and drawing, and volunteers with Cakes for Kids. Her greatest joys come from being a devoted mother to her 9-year-old daughter and a loving caregiver to her active 3-year-old stepdaughter. Without further ado, please welcome Shannon.
Welcome to this recorded webinar, Part 2, Trends in Injection-Related Complaints. My name is Shannon Trapp. I'm a pharmacy manager here in Winnipeg, Manitoba. Additionally, I hold the position of chair on the Complaints Committee at the College of Pharmacists in Manitoba. I'm receiving a speaking fee from the college for facilitating this segment of the professional development learning activity. After watching this webinar, pharmacists with injection certification should be able to, number 1, understand the training requirements for gaining and keeping injection authorization. 2, recognize and put into practice essential elements from the practice direction, administration of drugs, often overlooked in real-world situations, which can lead to complaints or unsafe care. 3, grasp the documentation and record-keeping rules related to drug and vaccine administration through injections. 4, comprehend the medication incident reporting procedures in the context of administering drugs via injections. 5, apply effective strategies for managing errors or addressing complaints related to injections. Please be advised that completing this program does not grant authorization to administer injections. It serves as additional learning for those already authorized. The topics of aseptic technique, shoulder injury related to vaccine administration, SERVA, and landmarking are extensively covered in Part 1 of this learning activity. In this Part 2 session, we'll dive into how to get and maintain injection authorization, reviewing sections of the administration of drugs, including vaccines practice direction, that are often overlooked and can lead to complaints through case-based examples, understanding the implications of failing to follow aseptic and landmarking techniques through real cases, effective strategies for managing injection-related errors, emphasizing the importance of promptly entering vaccination records into PIMS, and essentials of proper documentation and record keeping. Recently, the college has received complaints regarding pharmacists who administered injections without proper authorization. This happened for a variety of reasons. Some pharmacists didn't realize they needed to apply for injection authorization. Others wrongly assumed that completing the Manitoba training module and having a valid CPR certification automatically granted them this authority. Some misunderstood the process, thinking it was a one-time application, not realizing they needed to acknowledge meeting the requirements annually during license renewal. Administering drugs or vaccines via injection is considered an advanced method. A pharmacist may administer a drug using an advanced method only if they hold a current authorization in that method. To gain this authorization, pharmacists must apply to the College of Pharmacists of Manitoba. You can find the application for authorization to administer drugs and vaccines by injection on the CPHM website. Please note that you must apply and receive confirmation of an authorization from the college within a year of completing the required training or graduating from a Canadian Faculty College of Pharmacy. Otherwise, you'll need to undergo full retraining. It's crucial to understand that falsely claiming injection authorization is a violation. Section 117 of the Pharmaceutical Regulation states that no member may represent that they are certified in an advanced method unless they hold current certification under this part. As you are aware, there are specific requirements that must be met to apply for authorization to administer injections. Administering drugs and vaccines via injection falls under an expanded scope of practice. To qualify, pharmacists need to complete additional education, which has been approved by Council and successfully finish the Manitoba module on administration of injections. Additionally, pharmacists must hold certification in CPR Level C, or HCP, and possess emergency or standard first aid certification from an in-person training program recognized by the Workplace Safety and Health Branch of the Manitoba government. It is important to emphasize that completing the educational requirements and having valid CPRC certification does not automatically grant you authorization to provide injections. To gain this authorization as an expanded scope of activity, you must apply with the college and receive approval. Only then are you permitted to engage in this practice. As a pharmacist authorized to administer injections, it's crucial to be aware of the requirements to maintain your injection authorization. One point that often confuses registrants is that you need to declare your CPR and first aid expiry date in your member profile on the portal. When your CPR or first aid certification expires, your injection authorization is automatically removed because valid CPR and first aid are prerequisites for injection authorization. It is your responsibility to uphold these requirements, including having up-to-date CPR and first aid. If you allow your CPR or first aid to expire, your injection authorization will be revoked. You must reapply once you've renewed your CPR and first aid training. Simply renewing CPR or first aid after it is expired does not automatically reinstate your injection authorization. If you continue administering injections after renewing expired CPR or first aid without reapplying for injection authorization, you are in violation of the regulation and subject to potential complaints. Some pharmacists have mistakenly assumed that they retain injection authorization after their CPR expires and have resumed administering injections without reapplying for injection authorization after completing the required first aid or CPR program. The goal of this educational event isn't to recite the administration of drugs, including vaccines practice direction word for word. We assume that you've already made yourself familiar with its content and have experience administering many injections. Instead, we aim to spotlight and elaborate on specific aspects of the practice direction that often lead to complaints reviewed by the Complaints Committee. This will allow us to pause and delve into what the practice direction truly means in these scenarios and discuss the expected conduct. We will also explore 2 case studies to present these concepts in an educational and practical real-life context. With this in mind, on the following slide, there are a few key topics in the practice direction that I would like to address directly. This isn't an exhaustive list of all the requirements outlined in Section 2.2 of the practice direction, but it highlights some of the key ones that the Complaints Committee often encounters as the basis for complaints. 1. Comply with Standard of Practice Number 5, Administration of Drugs, Regulation 56.1.5, which means administer drugs with the patient's consent, maintain policies and procedures for drug administration, and be ready to respond in emergencies, like anaphylaxis. Interestingly, we've observed that some pharmacies lack proper policy manuals for injecting procedures, which are meant to provide clear written guidance on various pharmacy functions. This manual should cover everything from obtaining consent to documenting injections. It's a dynamic document that's regularly reviewed for improvements, especially when incidents involving injections occur. Only administer drugs in facilities suitable for administration. While it may sound obvious, we've received complaints about unsanitary, non-private, and unsafe injection areas, which we'll discuss further. 2. Stay updated with immunization guidelines like those from Manitoba Health and Seniors Care and the National Advisory Committee on Immunization. This became evident during COVID-19 when patients were denied vaccinations they were eligible for due to misinformation. 3. Maintain current first aid and CPR certification as recognized by the Council, as we've previously discussed. While I can't imagine why anybody would risk administering an injection without proper emergency kit, there have been instances where field operations from the college during inspections found either no or an expired epinephrine in the emergency kit of pharmacies offering injections. Anaphylactic reactions are rare, but pose a significant risk to patients receiving injections. Additionally, this presents a substantial liability risk for the pharmacist providing the injection. So, ensure your emergency kit is complete and up to date. Now that we've covered the requirements, let's put that knowledge into action with our case studies. Case 1. Ricky, a 53-year-old male, arrives at his local pharmacy for his annual flu shot. Waiting in the council room, the pharmacist enters with a tray full of injection supplies. Ricky notices the vial used to withdraw the vaccine has a syringe needle inserted into the top, but no syringe attached. The pharmacist does not wash their hands, nor wear gloves. They remove the needle cap with their teeth, akin to removing a pen cap. The room is cluttered, and the pharmacist has a hard time orientating themselves opposite Ricky. They simply pull up his shirt sleeve and stick the needle into his upper arm without actually touching the arm. The pharmacist tosses the syringe onto the counter. Ricky immediately experiences pain upon injection, more so than he typically remembers. The next morning, Ricky is jolted awake by the severe pain in the same arm he got the flu shot. He takes ibuprofen without much relief. Over the next 48 hours, Ricky feels worse and is having difficulty raising his arm without significant pain. He decides to return to the pharmacy to speak to the pharmacist who gave him the injection. When Ricky arrives at the pharmacy, the pharmacist who gave the injection is not there. He speaks with the pharmacy manager, who brushes off his concerns with a dismissive nature. Ricky asks if the injection was given too high. In a defensive manner, the pharmacy manager tells Ricky that all their pharmacists have undergone appropriate injection training, so there is no way the pharmacist could have made a mistake. Ricky is told arm pain is a common side effect of the vaccine. Feeling that something was not right, Ricky asks if the pharmacist who provided the injection could be advised of the situation. 5 days later, Ricky's arm is still in pain, so he calls the pharmacy. He speaks again with the pharmacy manager. Again, the manager is dismissive of this discomfort Ricky is experiencing and does not acknowledge that an administration error could have occurred. When asked if the pharmacist who provided the injection was made aware, the pharmacy manager said he was a relief pharmacist and didn't know when he would speak with him next. Again, Ricky is told that a sore arm after an injection is normal and not to worry. Ricky goes to see his physician and is diagnosed with shoulder injury related to a vaccine administration, CERVA. Ricky informs the pharmacy manager and files a complaint with the College of Pharmacists of Manitoba. This case illustrates several issues that the Complaints Committee is seeing involving vaccination. Let's consider each of these concerns more specifically in the next few slides. Section 2.4 of the Injections Practice Direction outlines the activities and requirements that must be fulfilled before administering an injection. I won't cover them all, but I'll focus on what's relevant in this context. In this case, the patient mentioned that the room was so cluttered that the pharmacist had trouble positioning themselves properly to administer the injection. This is clearly problematic because it can affect the ability to accurately landmark and could lead to various injection-related issues, like accidentally poking the patient before the intended injection, or even sticking oneself with the needle, among other concerns. It is crucial to consider this from the patient's perspective. They're about to receive a vaccine from you. If the room appears untidy, it might create a perception of uncleanliness or raise questions about the pharmacist's ability to perform the injection, since the room state can reflect on the pharmacist's practice. Administering a drug or vaccine by injection is an advanced method, so the environment where it's done should be clean, orderly, and free of unnecessary clutter. Section 2.3 of the Injections Practice Direction outlines the requirements for infection control, which you can see listed here. Before we discuss the specific concerns in this case, it is essential to emphasize the first point on this slide, handling all body fluids and tissues as if they were infectious, regardless of the diagnosis. This is a fundamental concept of universal precautions that everyone must follow. Now, in this particular case, there are several significant areas of concern. The pharmacist didn't wash their hands or wear gloves. Proper hand hygiene is a must to prevent infection. While wearing gloves isn't a strict requirement, at the very least, hands should be thoroughly washed with soap and water before and after the injection. Here are some important points to consider. The pharmacist had a vial with a venting syringe in place, which is not permissible unless you are in a sterile hood, something that's not feasible in a community pharmacy setting. Having a venting syringe in the vial, storing it in the fridge like that, and withdrawing the vaccine outside of a sterile hood can introduce bacteria to the product, potentially causing an infection upon injection. It is advisable to review the proper procedure for withdrawing drugs or vaccines from vials, which includes displacing the desired volume with air to balance the pressure difference when withdrawing. The pharmacist removed the needle cap with their teeth, which is not only unsafe, but also unsanitary. The pharmacist didn't adequately prepare the injection site by not using an alcohol swab to ensure it was clean. And the used syringe wasn't properly disposed of. It was simply tossed onto the counter. This introduces safety and infection control concerns. The used syringe left on the counter could be handled by staff or another person in the room, posing a risk of needle stick injury. It also represents a biohazard for the pharmacist, other staff, or anyone else in the room. As mentioned a few slides ago, the room's cluttered condition prevented the pharmacist from safely and properly positioning themselves, leading to improper landmarking of the site of injection. Proper landmarking is a fundamental and critical process in the administration of injections. It holds significant implications, including the efficacy of the drug or vaccine being administered, and is the primary way to reduce potential adverse effects following an injection. While the proper landmarking technique is covered in part 1 of this learning activity series, it's worth noting that eyeballing is not considered proper landmarking. There is no such thing as a no-touch landmarking technique, and once again, it is essential to prepare the injection site correctly, as we've discussed earlier. We all understand that errors and complaints will happen. A crucial message from the College of Complaints Committee is that, in many cases, mishandling the aftermath of an error has elevated the matter into a formal complaint. Surprisingly, the committee has found that registrants sometimes respond coldly, they lack sympathy or empathy regarding what has transpired, and occasionally, registrants don't admit to the error, or they act defensively or aggressively toward the patient, giving the impression that they are deflecting blame, downplaying the patient's experience, and avoiding accountability. When an error occurs, patients want to be heard and treated with compassion. They want their mistake acknowledged, thoroughly examined in a transparent manner, and steps taken to prevent its reoccurrence, not only for them, but for others as well. An essential point here is that your actions and interactions with the patient can significantly influence whether the patient decides to file a formal complaint with the college. If handled well, there's a good chance they may be satisfied with your response and accountability. You have control over whether the situation escalates. As this slide highlights, in this case, no apology was offered, even though the Apology Act makes it clear that an apology is not an admission of guilt and cannot be used against you in a court of law. So don't hesitate to apologize. It goes a long way in building goodwill with the patient. There were aggravating factors in how the complaint was handled, which led to the patient to file a complaint with the college. First, the pharmacy manager failed to show any empathy or concern over what had happened. For the patient, who associates their pain with the injection received at this pharmacy, this lack of concern would be both frustrating and alarming. The pharmacy manager was dismissive when the patient asked if the injection was provided too high, stating that all the pharmacists were trained, so there was no way the injection was given incorrectly. In this situation, it would have been appropriate to acknowledge that pharmacists are trained, including landmarking, but to also consider the possibility that the injection may have been given too high, which could result in the pain the patient is experiencing. Additionally, There was no in-depth questioning to extract more information about the nature of the patient's pain. It didn't sound like a typical sore arm from an injection. Given the immobility of the patient's arm, the pharmacist should have considered the possibility of shoulder injury related to vaccine administration, CERVA, and recommended seeking medical care. The patient expressed a desire to speak with the pharmacist who administered the injection, but the pharmacy manager was dismissive, saying they were a floating relief pharmacist and didn't know when they would speak with them again. This is inappropriate for several reasons. The injection pharmacist was not informed of the issue, so they couldn't apologize or intervene in an incident they were involved in. The injecting pharmacist remained unaware that there may be an issue with their injection technique and continued practicing without making necessary changes. The patient may want the ability to directly communicate with the pharmacist who provided the injection to discuss the possibility of the injection being administered too high. The patient may want an apology directly from the injecting pharmacist. The pharmacy manager didn't mention that the situation was taken seriously, investigated, and steps were being taken to prevent it from happening again. Because the pharmacy manager didn't view this as an incident, there was no incident report, investigation, analysis, or implementation of changes and policies and procedures to prevent such incidents in the future. The purpose is not to review the MI&NMPD in its entirety, but to review snippets of it and look at it from the perspective of the patient and come to understand that by following the practice direction, you may in fact address the matter sufficiently with the patient that they may believe that the incident has been taken seriously and not elect to make a formal complaint. Just to review some definitions, a medication incident is a preventable situation that may lead to patient harm. Receiving an injection incorrectly that causes CERVA is an administration error that is included in this definition. A near-miss event, which is discovered before reaching the patient. In this case, Ricky experienced patient harm, so this would be a medication incident. Additionally, the patient informed the pharmacy manager that after seeing their doctor, they've been diagnosed with a case of CERVA. This must prompt the pharmacist to create an incident report. Let's take a closer look at the key elements of the medication incident handling process, as outlined in Section 3.2 for community pharmacies in the medication incident and near-miss practice direction. We'll delve into each of these elements on the upcoming slides and connect them to the case in question. The first step in handling a medication incident is discovery. As indicated on the slide, the pharmacist made aware of the incident must determine if the patient has experienced harm or is at risk of experiencing harm. This determination is always central and the initial step when dealing with a medication incident. In this case, when Ricky first returned to the pharmacy and shared his concerns with the pharmacy manager, the manager was dismissive and didn't consider the possibility of CERVA from the injection. If the pharmacy manager had asked more probing questions about Ricky's range of motion, the type and intensity of pain, they might have considered CERVA at that point and directed Ricky to seek medical attention. This would have led Ricky to being seen by a physician on day 2 following the injection, rather than day 7. Regrettably, even during Ricky's second visit to the pharmacy and interaction with the pharmacy manager, it still wasn't recognized that Ricky was experiencing harm from the injection, and he wasn't referred to a physician. The point on this slide about notifying the pharmacy manager about the incident is crucial. While Ricky did speak directly with the pharmacy manager in this case, there have been instances where the pharmacy manager was not made aware of the incident when a complaint was reported. The pharmacy manager is responsible for the entire operation of the pharmacy and should be informed when an incident occurs. However, this doesn't mean that a staff pharmacist can't be involved in dealing with the incident, especially when immediate attention and resolution are needed in the absence of the pharmacy manager. Equally important is the requirement to notify the prescriber of the incident. The prescriber needs to be informed about what happened, what drug the patient received, and any specific directions. The prescriber may want to see the patient immediately for evaluation, provide guidance to the pharmacist following the incident, or consider its impact on future therapy. There have been instances where the committee found that the prescriber was unaware of a medication incident underlying the significance of this step. The next step in this process is disclosure and apology, and it involves several important actions. Acknowledge and apologize. Many patients want to know that a mistake occurred and receive an apology. Listen. It's crucial to not dominate the conversation or try to get your point across. Over-talking can make the patient feel unheard, that you don't care, or that you're trying to protect yourself or your staff. Advise. Advise the patient of potential consequences. This can be a difficult conversation, but it must be had as the patient has the right to know. For example, Ricky has the right to know that his condition could be SIRVA, so he can make an informed decision about the treatment he wants to seek next. Inform the patient about known facts and update them as new facts emerge. Patients want to understand the why and how. They also want to know any additional information you have found through your investigation. This shows that you are taking the matter seriously. In Ricky's case, it would be appropriate to inform him that you would advise the pharmacist who gave the injection and ask if you would like a call from them. Some more on the disclosure process. Again, we've discussed before, but advise the patient that the pharmacy manager will be informed of the incident. This demonstrates transparency and accountability. The person in charge will know and it won't be swept under the rug. Advise the person that anonymously the incident will be reported to a national medication incident database so that others can learn from this and be prevented from happening to others. This may be appreciated. Ricky may appreciate that this incident will be shared with other pharmacists so that they realize this can happen if an injection is not administered properly. Advise the person that an investigation, both regarding the root cause and changes that can be made, will occur. Again, people want to know the matter will be looked into, the why and the how, and then what will be done differently to prevent it from happening again. In this instance, Ricky may want to hear that the pharmacy manager reviewed injection technique, aseptic technique, and addressed the clutter in the room with the pharmacist. This would be reassuring to the patient and may make them feel heard, may make them feel like the matter was addressed, and increase their satisfaction with the handling of the issue so that they feel less inclined to lodge a formal complaint. Next is the investigation phase. Notice the PD says the pharmacy manager must ensure that the staff member involved in the incident is made aware of the incident. Reasons for this have already been said, but include giving a chance to the pharmacist to apologize and intervene on the matter, which could abate the patient's desire to make a formal complaint, and would serve to notify them that there may be an issue with their injection technique and afford them an opportunity to review same. A key component of the investigation phase is that the investigation is done in an open, transparent manner that does not impart a shame and blame culture. No one wants an incident attached to them, and it's not a good thing if they're happening regularly, but it must be approached with what is the root cause, what things can change to prevent it from happening again, and what did we all learn from it. As stated previously, the patient should be notified of the findings and any changes that have resulted from the investigation. It might assist with Ricky in reestablishing trust with the pharmacist and the pharmacy if he knows that changes have happened to prevent this from happening again to him or someone else. Continuing with a few points of the investigation phase. By informing the patient, in this case Ricky, of the action plan that resulted from the incident, it would in effect close the loop with the patient. All findings and changes that are being implemented must be shared with staff. One critical part of the process that many managers neglect is to make changes to the policy and procedure that reflect what is changed due to the incident. Many seem to think it's a simple staff meeting, but that isn't sufficient. Sometimes not all people are at the staff meeting. Staff can change, managers change. Relief staff may come into the pharmacy and need to reference what is expected to complete various functions in the pharmacy. These are all reasons why the changes must be documented in the policy and procedure manual. As mentioned previously, medication incidents are promptly and anonymously reported by pharmacy staff members to Medication Incident Reporting Platform, which will export the report details to a national medication incident database. Although not all near misses need to be reported, any near misses that are recurrent or could potentially cause harm, if not corrected, should be reported in order to identify trends and provide recommendations. This brings us to the second last phase of handling of medication incidents in a community pharmacy setting, analyzing incidents and near misses for opportunities for improvement. This should be done by the pharmacy manager on a quarterly basis. Look at internal incidents, what's happening at your store, under the lens of improvement. Ask yourself, what can be done differently and better? Also, look at and compare yourself to national data. How do you compare to the national data? Were there any things occurring nationally that you could learn from and make changes to your process to avoid an error from occurring? This is exactly the purpose and spirit of the Safety IQ program. Unfortunately, the Complaints Committee is identifying that these steps are often not done or not taken seriously. Again, any changes you make upon analysis need to be communicated to staff and reflected in your policy and procedure manual. Lastly, a formal continuous quality improvement meeting must be conducted with pharmacy staff at a minimum annually, with informal huddles occurring as medication incidents occur and as deemed necessary. And finally, the last phase of handling medication incidents in a community pharmacy setting is documentation. We all know we are a documentation-heavy profession. However, interestingly, the Complaints Committee often sees via the response provided to a complaint or meeting with a registrant that documentation isn't always done, and sometimes when it is done, it's inaccurate or incomplete. Please be reminded that it is a requirement that all documentation be readily retrievable and open for regulatory review. In summary of Case 1, it is evident that multiple issues contributed to the incident and Ricky's decision to file a formal complaint with the college. However, there were several opportunities to handle the situation differently, which could have changed the outcome, including Ricky's desire to file a formal complaint. By following the required steps outlined in the MINMPD, such as discovery, disclosure, apology, investigation, reporting, and process analysis, you would demonstrate to Ricky that you care about the harm that occurred. This includes apologizing for the incident, providing the involved pharmacist an opportunity to apologize, conducting a thorough investigation to identify root causes, reporting the error, and analyzing your process for improvement. If the pharmacy manager had engaged with Ricky in an empathetic, compassionate, and transparent manner, Ricky might have felt heard, valued, and supported through this process. This approach could have laid the foundation to rebuild trust between Ricky and the pharmacy. Moving on to our next and final case study. Naomi presented to the pharmacy for her COVID-19 shot. The pharmacy was having a clinic day providing both flu and COVID-19 vaccinations, so there were many people in the waiting area. Naomi approached the pharmacy assistant at the intake counter and was told to proceed to the counseling room. She was provided a form that she was asked to sign at the bottom. Upon entering the counseling room, several of the same forms, which she could read, were on the desk in plain view. Naomi mentioned this to the pharmacist, Shirley. Shirley did not address the concern and asked her what vaccine she was expecting. Naomi advised that she was there for her COVID-19 booster. The pharmacist then said, okay, administered the injection, and advised Naomi she was free to leave. Since the clinic was quite busy, Shirley collected the consent forms as she provided the vaccinations and set them aside to deal with later. Shirley was busy the remainder of her shift and did not enter them into PIMS before leaving. 2 days after the vaccination, Naomi wasn't feeling well and decided to go to the pharmacy and ask some questions. Naomi was concerned she may have gotten the flu shot instead of the COVID-19 booster. Naomi identifies herself at the counter and explains that she'd been at the pharmacy's clinic 2 days prior and wasn't feeling well. She asked which vaccine she received. The assistant looked at her profile and advised that they have no record of her receiving a vaccine at her clinic. Both frustrated and alarmed, Naomi recognized Shirley and asked to speak with her. Shirley recalled vaccinating Naomi and told her she was pretty sure it was COVID-19 booster, since that's what Naomi had requested. Naomi asked her to verify. When Shirley goes to the area where she left the stack of consent forms, she cannot find them. A pharmacy assistant advised her that there was a large stack of paper in that area that was sent for shredding. Shirley then told Naomi she couldn't find her consent form, adding, "Don't worry, I know it was the COVID-19 vaccine." Naomi felt uneasy about this and makes a complaint with the College of Pharmacists in Manitoba. This case illustrates several issues that the Complaints Committee is seeing involving vaccination. Each of these identified issues will be discussed in detail over the next several slides. Just like dispensing a drug to a patient or patient counseling about a drug being dispensed, there are basic principles that must be adhered to. You, the pharmacist, must perform a review of patient medical vaccination history. Is this the right vaccine for the patient? Right time to get it? Any red flags to consider? How is the patient today? Are they ill or should they defer having the vaccine to a later point in time? Are they eligible for the vaccine via a publicly funded program? Additionally, you, the pharmacist, must obtain consent from the patient or the patient's agent. This consent document must be retained, be readily retrievable for regulatory review. You will note that all of these things are actually also required per Section 57 of the Public Health Act and immunization regulation we discussed in the previous case. This is not an exhaustive list, but I'll focus on what is relevant to the case. It is crucial to fully educate the patient about the vaccine they're about to receive before administering it. Providing this information allows the patient to make an informed decision about vaccination. Remember that if you provide this information after the vaccination, it can't be undone. For instance, some patients have wanted a specific COVID vaccine, but the pharmacist failed to inform them about the vaccine type they were administering. Only later did it become clear that the patient received a different COVID vaccine than they wanted. If the pharmacist had followed the guideline in the ADIV-PD, this could have been identified before the vaccination, and the patient could have been offered an option to wait for the desired vaccine. According to this slide, the patient must be aware of what the vaccine is, how the vaccine works, vaccine efficacy, administration procedure, expected adverse effects and how to address them, what is not normal, and when to consult a physician. Very much like checking a prescription for dispensing, there must be a final check by the pharmacist. Is this the right drug, right person, right dose, right time, right route? Sounds simple, but this does catch potential errors. There are numerous examples of what a final check has prevented, but some include preventing the patient from getting the wrong vaccine, preventing the wrong patient from getting a particular vaccine, consider busy vaccination clinics and numerous people there, preventing the person from getting injected with air and no drug, preventing the person from getting a booster injection too early, which would not be permissible, preventing the person from getting a brand of COVID vaccine they don't want, and many more. Again, not a complete list, but I will highlight what is relevant to this case. For many informal concerns and some formal complaints, it becomes evident that many pharmacists do not ensure the patient is appropriately monitored following injection. You should note that the language in the practice direction is you must. There is no option here. It is acknowledged that some patients do not want to wait and that you cannot make them wait if they do not want to. However, the expectation here is that when you are reviewing information on the informed consent, you will take a brief moment to review that you would like them to wait for a period of 10 to 15 minutes following injection and that the rationale behind this. Often, when you tell the patient why, they understand and are more willing to comply. Perhaps something like, following the vaccination, I would like you to remain in a chair in the waiting area for 10 or 15 minutes. This is because if you have an unexpected reaction to the vaccine, I have medication that can help you. If you're met with the question, can I just walk around or shop? You could respond by saying, this is your decision, but remaining seated is safer in case you feel unwell and fall. This way, the patient has been informed of your desire to wait following vaccination and why. Vaccinations are often given in pharmacy patient counseling rooms, although during the pandemic, we saw them administered in less private settings. But regardless of the location, protecting patients' personal health information is crucial. In this particular instance, consent forms from the previous patients were left visible to other patients. This would not be in compliance with VIA and the section on duty to adopt security safeguards. 18.1. In accordance with any requirements of the regulations, a trustee shall protect personal health information by adopting reasonable administrative, technical, and physical safeguards to ensure that confidentiality, security, accuracy, and integrity of the information. Consider obligations under section 19.012 of FIA regarding notification of an individual about FIA breach. This obviously would be a very uncomfortable conversation with a patient, having to call them and advise them that you left their records out in plain display for other people getting a vaccination to see. Additionally, our PD records and information speak more about the security of the patient records and what to do if there is a breach. 2.7 of Records and Information Practice Direction. 2.71, a pharmacy license holder must take appropriate measures to remedy a security breach as soon as reasonably possible after discovery of an unauthorized access, use, disclosure, or disposal of personal patient information. These measures include ensuring the security of remaining personal information, notification of affected persons, the college, and legal authorities, and modifying security measures to prevent a reoccurrence. So to clarify, in the event of a FIA breach, you must follow both FIA and the R&IPD, which includes informing the college. This is typically done by sending an email to the Field's Operation Division. Creation of a vaccination record and its entry into PIMS is a critical and important step. The language used in the immunization regulations is unambiguous. You must immediately record information into the patient's health record. Delay is unacceptable and inevitably results in additional problems. Consider this case where Shirley left a stack of forms in the pharmacy, which were ultimately unknowingly discarded by the pharmacy assistant. Now there are several other violations as a consequence: delay in entry and no consent forms, no ability to enter into PIMS particulars about the vaccination, such as time, arm vaccinated, lot number, etc. Also, in this case, Naomi has come back to the pharmacy questioning what vaccine she received. This should be easily able to be addressed by reproducing the consent form with all of this information. But because they were not archived properly and entered into Naomi's health record, the pharmacist cannot speak to this. This further elevates Naomi's concern and frustration, leading her to make a complaint with the college. One consequence of not promptly entering records into PIMS or DPIM that the pharmacists often do not think of is, what if the patient had a significant bad reaction at a later time, when the pharmacy is closed and the patient cannot communicate that they've had a drug by injection or vaccination to emergency personnel? Another healthcare professional may look at PIMS or DPIM, looking for something the patient has started or been given recently, and this would not be documented and therefore not considered as a possible cause of what the patient is experiencing. This slide further confirms, in another area of our legislation, the pharmaceutical regulation, that a pharmacist who administers a vaccine to a patient must enter it into electronic public health information network, like PIMS or DPIN, in a time that the minister requires, which is set out in the immunization regulation, immediately. I sense you are all picking up on a repetitive theme here, but there is a further guidance on reporting in the ADI-VPD. You will note that it differs to what the requirements are in Section 57 to 59 of the Public Health Act and the Immunization Regulation. Note the language used is a must, meaning there is no wiggle room. The pharmacist has to comply. This slide explains that according to the Pharmaceutical Regulations Section 113, a pharmacy is required to maintain its own vaccination records. The slide outlines what information these records must include. Let's take a closer look at the specific contents of these records. Part of the records to be contained in the consent form, it is noted that the consent form may have all the required elements to be documented as per 113 of the regulation, as listed on the previous slide. This is the pharmacist's proof that consent was obtained when providing the drug or vaccine. Again, the drug administration record and consent forms must be retained, readily accessible, and available for review. What may not be so obvious for some is the bullet point stating that you cannot rely on entry into PIMS as a pharmacy record. The reason for this is because pharmacies do not own PIMS. They have access per an agreement. Should this agreement be terminated for any reason, the pharmacy would no longer have access to the vaccination records. This is unacceptable and would be a violation of the regulation and ADIV-PD. Therefore, in some manner, the pharmacy must have its own administration record for drugs or vaccines provided by injection. As stated previously, if the content captures all of this information, this would be acceptable provided it is in the patient's health record and readily acceptable. In summary, Case 2 highlights several key issues. 1. Pharmacists must adhere to all components of the ADIV practice direction without selective omissions for convenience. Any violations may result in complaints. 2. Proper assessment and counseling of patients before vaccination are essential for informed consent. Observation after vaccination is equally important, which was not done in Naomi's case. She wasn't explicitly informed about the COVID vaccine, leading to her confusion and concern. 3. Leaving other patients' consent forms visible in the vaccination room is a clear violation of FIA, potentially leading to sanctions upon complaint. 4. Surely the pharmacist failed to enter vaccinations into PIMS due to being too busy. This error, compounded by an assistant disposing of consent forms, resulted in multiple violations. Naomi couldn't confirm her administered vaccine, causing anxiety and leading to a formal complaint. Maintaining proper records, as required by legislation, could have prevented this issue and facilitated a more patient-centered conversation about her well-being. 5. And pharmacies must maintain their own drug administration records as they do not own PIMS. Relying solely on the PIMS system for this purpose is insufficient. Moving on to a few more notable issues. The last slide makes a few important points. Adverse event following immunization must be reported within 7 days of becoming aware, with serious adverse events within 1 business day. This is a requirement of the Public Health Act and the Immunization Regulation. I will not review all of what is said in this legislation, but would encourage you to read it. There is also information on Manitoba Health's website in the immunization section as well. All adverse incidents following immunization need to be reported unless mild. And a very important point is that all adverse event reporting is not the same incident reporting as per the MINMPD. Medication incident reporting is a requirement of the pharmacist according to pharmacy legislation. And this brings us to the end of Part 2, Trends in Injection-Related Complaints. Thank you for joining.
We have reached the end of Part 2, Trends in Injection-Related Complaints. A special thank you to Shannon Trapp for sharing her insights and knowledge. On behalf of the Complaints Committee, we hope that you have gained valuable insights into the primary concerns brought before us and enriched your skill set as an injection-certified pharmacist. Your commitment contributes to maintaining a higher standard of care and safety within the field. Don't forget to complete the Learning Activity Evaluation form to receive your Statement of Participation and claim your CEUs. Thank you for your active participation.